This conference will now be recorded.
Okay, so am I audible to all?
Yes, sir.
Fine. So functional endoscopic sinus surgery is a you can say is a recent advance. Although after that lot of things have evolved, but it brought about a drastic change uh, in the way paranasal sinuses were operated. The concept of preserving the mucosa came into existence, and thereby the post-operative, what you say, the function of the sinuses came back pretty early, and patients were also very much satisfied. So now you can see, sorry. So now you can see that open procedures are very rarely done, but still they are done in few cases where the disease or the pathology has progressed beyond the functional endoscopic sinus surgery. So where the pathology is very large enough that you need a open procedure. So So before going into functional endoscopic sinus surgery, so a little bit of about diagnostic nasal endoscopy, because all cases of functional endoscopic sinus surgery has to you have to do a diagnostic nasal endoscopy before subjecting the case to FES. So the diagnostic nasal endoscopy is a OPD procedure done under local anesthesia. So you pack the nose with 4% lox and adrenaline, uh, and then you can use one ampule because you are just packing the mucosa, and you are by that what happens is the edematous mucosa in the nose, in the nostrils, they shrink, and that allow some space for the endoscopy to go in. So that what happens ki these are the not the fixed obstruction, little what you say, the dynamic one, where the mucosa can be shrunk to some extent, but if there is a gross septal spur and all, there it won't shrink because that is a fixed obstruction. But another thing is it gives anesthesia to the nostrils, because the what happens ki the moment you put something into the nose, the obvious thing is that sensation and patient starts to sneeze. So to prevent that, we keep local anesthesia, and after keeping it, wait for at least 5 minutes for the anesthesia to have its effect, and then remove the pack, and then you always use a 0-degree endoscope. So here in diagnostic nasal endoscopy, we use a rigid endoscope, and they are all 0-degree. uh, and why 0-degree? Because the orientation is very good or excellent with 0-degree, and endoscope is used because of two things. One is the optics and the illumination. The illumination enables you to see the deeper parts of the nostrils, which are not possible with anterior rhinoscopy examination, and the optics leads to a little enlarged and clear images. So now that depends on the type of camera that is used. Previously, all the we used was a single chip camera. Now the latest one are 3-chip camera, and where you get also a high definition quality of video and images. So the first pass goes along the floor of nasal cavity, and here you see the septum and the inferior turbinate, go right up till the guana, and inspect the nasopharynx, look for any adenoid tissue. You can see the eustachian tube opening, and just behind the eustachian tube opening is the fossa of Rosenweiler. And on withdrawing the scope in the inferior meatus, if possible, you can have a look at the Hasner's valve, which covers the nasolacrimal duct. So this the most important thing is, because you have anesthetized the patient, that doesn't mean that you can injure the mucosa. So at no point of time you should injure the nasal mucosa. So that is why you have to be very slow and make sure that you don't graze the mucosa, because particularly in case of diseases, the mucosa is already inflamed. The moment you graze it, it starts to bleed, and then you will only have the problem. You can't see the structures behind that. Then you have to do suction. The suction also causes some injuries. So here you can see the floor of the nose. This diagram is little bit not correct. The floor of the nose gradually slopes down like this posteriorly. It's not totally flat, and then you pass here along the floor. So you can see the inferior turbinate, the inferior meatus, and the eustachian tube orifice also you can see. Now the second pass, the scope is passed till the guana, and then along the roof of the guana, anterior sphenoid till medial to the middle turbinate. So second pass comes medial to the middle turbinate, and where you have a look at the sphenoethmoidal recess. So, and also you can see the superior turbinate and meatus, although it is not possible all the time, because if the middle turbinate has to be little bit mobile and should allow you to maneuver between the septum and the turbinate. Some patients, the turbinates are very hard, and you cannot move it, and you should not forcibly do this second pass, because if you fracture the middle turbinate is attached to the base of the skull. A patient might have a CSF leak. So always be very careful uh, when you are doing this particular pass. And you can also see the Woodruff plexus below the sphenoid osteum at the roof of the guana. So the third pass is called the pass which goes into and examines the middle meatus. So the middle meatus lies lateral to the middle turbinate, and here the moment you approach the middle meatus, you can see the anterior one-third attachment of middle turbinate to the cribriform plate. So this is what I was talking about. The attachment of middle turbinate to cribriform plate is very delicate. If you fracture there, no, then there is a chance of CSF leak. Then you can see the uncinate process also, and just behind the uncinate you can see the bulge of bulla ethmoidalis, and you can also appreciate the hiatus between the bulla and uncinate. And the second part, then if you go still deeper or posterior in the middle meatus, you can see the ground lamella, where the middle turbinate turns laterally behind the bulla to attach to the lamina. So the ground lamella you can very easily appreciate. Now if you see the attachment of middle turbinate, now anteriorly the attachment is in sagittal plane, in the middle it is in the coronal plane, and posteriorly it is in the axial plane. So that the middle turbinate is attachment changes as you go from anterior to posterior. So this ground lamella is a very good landmark in endoscopic sinus surgery. So this ground lamella separates the anterior ethmoidal cells from the posterior ethmoidal cells. So when you are doing a surgery, endoscopic sinus surgery, you have to try to preserve the ground lamella. Why? Because of one is it is a good anatomical landmark for a revision surgery, and second is it also helps in stabilizing the middle turbinate. Now, unnecessary totally removing the ground lamella, what happens? Now the middle turbinate, which was having three attachment, now has only two, so it becomes more unstable. So to prevent, to give more stability to middle turbinate, some part of ground lamella is not touched at all. Then the third part of middle turbinate is the horizontal part, which forms the roof of the middle meatus, where it goes and attaches to the palatine bone. So in some cases, you might appreciate a second opening that is called as the accessory ostium, which may be antero-inferior to or anterior end of the uncinate, or posterior-superior to posterior end of the uncinate. So these two areas are the known as the frontanelles, that is anterior frontanelle and a posterior frontanelle. So the difference between the true open ostium and the accessory ostium is the accessory ostium are usually present either anterior or posterior to the true ostium, and the true ostium can never be seen with a 0-degree endoscopy, and but the accessory ostium can be seen. So, and it is the antroconal polyp usually comes out through the accessory ostium and goes posterior. So these are few differences. Then we are still with the what you say, the second pass, and then you can just probe, take a ball probe and probe into the hiatus semilunaris, which is just behind the uncinate process. So so this completes the third pass. So all these three passes should be done with the least trauma to the mucosa. So very important. The sole purpose of endoscopic sinus surgery is to preserve the mucosa as much as possible. So if you are doing injury to the mucosa during DNE, then that is not correct. So then slowly, then this finishes the what you say, the three passes, and then important is the first is preservation of nasal and mucosal lining with the ostium, and usually done in minimal disease, but now with the advent of latest machinery like the micro debrider and all, even extensive nasal polyposis also you can very nicely do with endoscopic sinus surgery. Then another is called marsupialization endoscopic sinus surgery, or MES, where removal of diseased mucosa is done, and it is particularly done in revision cases and in extensive diseases. Now, indications, there are quite a few indications. One is failure of conservative treatment for sinusitis, because now if you go through the textbook, most of the textbook, in a standard textbook, they write that the try to manage a case of chronic sinusitis with medical treatment as much as possible. And they say that very rarely you require surgical intervention. Then number two is polyposis, recurrent and chronic sinusitis, and then epiphora. Epiphora is seen particularly when there is some obstruction to the nasolacrimal duct. So here you can go and do a endoscopic dacryocysto-rhinostomy. Mucocele of paranasal sinuses, then orbital complication of acute sinusitis, like patient presenting to with orbital cellulitis or abscess, you have to, or even optic nerve decompression also can be done. using an endoscopic sinus surgery. Septal spur, definitely you can do, that is endoscopic septoplasty. And there are other few indications which are not mentioned here. I will tell you. You can write it down. The CSF rhinorrhea, a very important indication is the rhinorrhea, the CSF leak, which can be repaired. Then you have even you can do endoscopic medial maxillectomy, which is done in for cases like inverted papilloma. Even endoscopic ligation of spinopalatine artery can be done, and even you can do a endoscopic removal of a juvenile nasopharyngeal angiofibroma, which are being popularized by now instead of doing a open surgery. Then you can also do endoscopic approach to the pituitary. So, particularly pituitary adenoma can be addressed using endoscopic sinus surgery. So, there are a lot of indications, and even beyond that, also people are operating with the help of endoscope, that is doing clival, chordoma, and all those things. Uh, which is not required for your level, but this much is enough, doing a endoscopic removal of pituitary adenoma. Now, contraindication is osteoma, but still, although it is a contraindication, I have seen surgeons operating with the help of endoscope. That is endoscopic approach, that is called as the endoscopic modified Lothrop approach or draft 3 approach for osteoma, particularly of the frontoethmoid complex. Intracranial complication, you can also use endoscopic sinus surgery, but in some cases you have to take the help of the neurosurgeon, and they usually rely on the what you say the open approach. Then osteitis and osteomyelitis of frontal bone, if it is extensive, then obviously you have to go for a open approach. And in these conditions, although it is written contraindication, but still some centers they still go ahead and do endoscopically to some extent and combine it with an open approach. They do it. So pre-operative workup, very important after doing a diagnostic nasal endoscopy. Then next workup is you have to do a CT scan of paranasal sinuses. Now, but a important thing you have to remember is if there is a acute sinusitis, then immediately don't advise CT scan, but give a treatment for at least a week to 10 days, antibiotics, steam inhalation, and then you do the CT scan. So then you will exactly know how much of residual disease is there, and whether this residual, because sometimes what happens, no, these infection, no, can totally disappear with treatment, antibiotics. So in those conditions, if you do surgery, then it is unnecessary you are meddling with the nasal and paranasal sinus mucosa, so which is not advisable. So CT scan, and usually we ask for the bone window, and coronal cut is the most favored one. Although we require all the three cuts, that is the axial as well as the sagittal. The sagittal cut is very good to see the frontal recess, the base of the skull, even the sphenoid also. And the coronal cut is just like a roadmap for the surgeon. What, because It starts from anterior and goes posterior, and then the surgeon, by following the cuts, can make out how the pathology is spreading from one place to another. And then, in case of massive polyposis, usually we don't jump in and do the surgery, but we have a protocol. We give steroids and antibiotics, steroid not oral but intranasal, and antihistaminics for at least a period of 2 to 3 weeks before subjecting the patient to any surgery. Why? Because the steroid not only it reduces the size of the polyp, but it also has an anti-inflammatory property. So what it does, it by reducing the inflammation, even it reduces intraoperative bleeding also. So that is why, and this oral steroid it just started 1 week before the surgery. And sometimes if you are anticipating a fungal disease by seeing the CT scan itself, then you can also start antifungal drugs. We usually give here itraconazole. You can also give voriconazole or fluconazole, and so that what happens, it also takes care of the fungal elements and also reduces the fungal load. Now, the position, the head elevation, usually we ask for, because what happens when you elevate the head, no, it reduces the CSF pressure, and thereby it reduces even the bleeding to some extent. So, but when you are doing a frontal recess approach, you need to go for little extension. But even without that also, when if you have a good 70-degree endoscope, you can have a look into the frontal recess without even extension also. So the sister stands opposite to the surgeon, and this is either the what you say, the monitor will be opposite to the surgeon or in the head end of the patient, depends on the preference of the surgeon. And CT scan on the view box, head drape and whole towel exposing the nose and eyes. So usually what happens now, in most of the surgery, if well, it's unfortunate that you are not able to go to OT now. After intubating, now the anesthetist, they close the eyes, and because to prevent it from drying, so they apply some ointment, mostly neosporin, and they put a small paper plaster so that it doesn't open. But this is one surgery, but where we tell them not to put the plaster and keep the eyes open. So we just advise them, you keep the ointment and leave the eyes open for us. Why, I will tell you. Anesthesia, GA or LA, here though we all do under general anesthesia, but there are centers who do it exclusively under local anesthesia, and they have good patient compliance also. But it's few conditions you require general anesthesia, particularly in children. You have to give general anesthesia. In an apprehensive patient, obviously general anesthesia should be given. And in revision surgery, it is always better to give general anesthesia. Local anesthesia gives excellent hemostasis and visibility, because the main drawback here is general anesthesia is bleeding. But now that they have also, as our surgery has evolved over the age, over the period of time, even the anesthetic techniques and drugs have also evolved, and now they are giving what is known as a hypotensive anesthesia. So hypotensive anesthesia is where the blood pressure is knowingly kept at a lower level. Not only the blood pressure, but the heart rate is also kept under check. So thereby it reduces the bleeding. So there are a lot of drugs which are being given, like sevoflurane is one of them. Where our people use a lot of sevoflurane, and then next is there are you can give a total intravenous anesthesia, that is TIVA, which also causes hypotension, and you can also give nitroglycerin IV drip to reduce the blood pressure, and they are also giving esmolol to reduce the even the heart rate also. So there are few drugs which are given particularly to check the rise in blood pressure. Then again, a pre-operative nasal packing is required, even though you might ask a question, sir, you are doing under general anesthesia, why you want to pack the nose? Because you have to decongest the mucosa. Once you decongest the mucosa, no, what happens the moment you keep some incision, or then it starts to bleed. So decongestion of mucosa, and also what happens key, it allows instrumentation. So it allows the endoscope, it allows the one more forceps to go and out. So you have to give a proper no packing of the nose and leave it for 5 to 10 minutes and totally decongest the. So few surgeons what they do, they use very high percentage of adrenaline while nasal packing, because they say ki, we are only decongesting the mucosa, so there will be hardly very limited amount of absorption into the systemic circulation. So already you are putting adrenaline to it. The adrenaline will also prevent absorption into the systemic circulation. And why they give high percentage of adrenaline is they don't infiltrate. So they say ki the moment you start infiltrating, no, it starts to bleed and doesn't stop, and then that it causes a lot of problem. So why to infiltrate and why to cause bleeding? But if you are doing it under local anesthesia, you have to have a good infiltration, otherwise the patient will be moving and complaining of pain all the time. So infiltration with 1% lidocaine in 1 lakh adrenaline to uncinate, the attachment of middle turbinate to anesthetize the anterior ethmoidal nerve. So here you also have to infiltrate the inferior turbinate, the septum also. Because why septum? Because when you are putting in the endoscope, no, it might come and touch the septum also. So because you are doing under local anesthesia, the patient should not get the sensation of something entering into the nasal cavity. Otherwise, this sneeze reflex will automatically start. And then the middle turbinate and the uncinate needs to be uh, given anesthesia. And then another is posteriorly in near the spinopalatine foramen. So because they also to anesthetize the spinopalatine nerve. So very very important. The spinopalatine block goes a long way in helping or giving anesthesia to the patient. Correction of deviated septum, some cases you have to do, particularly if the deviation is preventing the instruments to enter, then initially you have to correct the deviation and then go ahead with the endoscopic sinus surgery. So the first step is known as the uncinectomy, and you know the uncinate is a crescent-shaped bone, and it has a vertical process, an intermediate process, and a horizontal part. It's a vertical part, intermediate, and a horizontal part. So the uncinate has numerous attachment horizontally or inferiorly. It attaches to the inferior turbinate, and the vertical process has attachment to the lamina papyracea, to the lacrimal bone, and to the ascending process of the maxilla. So, and the posterior border is free. So the uncinate posterior border is free, and the uncinate is just like a, what you say, just like a door. So the with the hinge, where the door can be, you can swing the door back forth. The uncinate also can move back forth, and the function of uncinate is it helps to ventilate the maxillary sinus during expiration. So as you know, all the sinuses are ventilated during expiration. So the uncinate goes a long way in helping to ventilate the maxillary sinus. So that is why previously everyone when this surgery evolved, and everyone wanted to remove the uncinate completely without knowing that they are damaging the patient, causing damage to the patient. And so now this has also evolved with time, and now the dictum is not to remove uncinate unnecessarily until and unless in two or three conditions. One is where the uncinate is also involved in extensive disease like polyposis. So fungal polyposis can involve any part. So if it involves the uncinate, then obviously you have to sacrifice it. And in number two is when you are planning to do a frontal recess approach. So in those conditions also you have to go for a total removal of the uncinate. So how it is done, I'll just show the picture here. See, this is the uncinate, you can see, and this is the uncinate. And the uncinate, although it is looking here, the uncinate has the upper border of the uncinate, no, can attach in three ways. One, it can go and attach to the lamina papyracea here, like this. It can go and attach to the skull base here, and it can go and attach to the middle turbinate here. So there are three. So these three different attachment of the uncinate dictates where the frontal will drain. So the upper attachment of uncinate will dictate where the frontal sinuses will drain. Now, if it is attached to the what you say, this is the lamina papyracea, the drainage will be medial to it. If it is attached to the skull base, the drainage will be lateral to it. And if it is attached to the middle turbinate, the drainage will be lateral. So, so if it is attached here, no, they will drain directly into the middle meanders. But here, in particularly, if the uncinate has an attachment with middle turbinate, the drainage will occur into a blind recess that is called recessus terminalis. Okay, so this is how the upper attachment of uncinate will dictate where the frontal will drain. So here you can see the uncinate has been trimmed off, and here totally they have removed even the superior process also, and they have also done the bulla epimodalis has also been removed here. So the osteometal complex is clean. Here you can see this is the middle turbinate, this is the anterior attachment of middle turbinate, and this elevation here you can see this is the nasolacrimal duct elevation, and here you can see this is the uncinate bone. Okay, so then just they have marked the uncinate bone here, and so you can see the so how to know the attachment, anterior attachment is you take a ball probe and you insert it into the hiatus, and then you pull the posterior free border anteriorly. So when you pull this free margin anteriorly now, you can see the attachment of the uncinate. So by seeing, you can give the incision there. So either you use a sickle knife, which few people also use till now, till date, and or you can use a backbiting forceps or the ostrom backbiting forceps. So among the two, the safest one will be the use of backbiting the sickle knife, those who use, as you go up, because the attachment of the superior attachment is there to the lamina papyracea, so that every point there is every chance that at the superior end you might injure the lamina papyracea and enter into the orbit. So that risk is there. So in those conditions, it is always better to take the backbiting forceps and then identify. So you can see this is the vertical part and this is the horizontal part. So this is the intermediate part. So this intermediate part is the area where the natural opening or natural drainage of maxillary sinus will be present. Next part, you can see they have made the incision and they have elevated it completely nicely, because it's a cadaveric dissection and there is no bleeding, but routinely if you see it will bleed. So now you can see the uncinate has been removed, and here you can see going superior to the attachment, just close to the lamina papyracea. This part I was talking about, we have to be very careful here. This will be attached to lamina papyracea. So, and here, sorry. So after you remove this, the next structure you see is the bulla ethmoidalis. So this uncinectomy, the moment you remove the uncinate, you uncover the hiatus semilunaris, and then you also see the bulla ethmoidalis, which you can appreciate here. So the bulla ethmoidalis is the most permanent and prominent, the most prominent and largest of anterior ethmoidal hair cells. Okay, are you following?
Yes, sir.
Achha, good. So, if there is any doubt, you ask me in between. Feel free to ask the doubt. So, you can see the bulla ethmoidalis here. Now, the bulla ethmoidalis is a very important landmark because it represents the anterior ethmoidal air cell, and it is the largest anterior ethmoidal air cell. Now, the bulla ethmoidalis also nematization varies. In some condition, the bulla will be very well nematized, and in some condition, it will be very ill nematized. So then in these two situations, now there is lot of differences. So if the bulla is very well nematized, just think that the once you then there is it goes up to this base of the skull. It goes up to the base of the skull, and posteriorly it extends up to the ground lamella. So once you remove the bulla, and then you reach the ground lamella, and superiorly you are flush with the base of the skull. So this you can know when you do a CT scan of paranasal sinuses. So they will give you a very clear cut what you say, the dimension of the bulla ethmoidalis. Now, if the bulla is very well nematized, and then what you do is, after doing an uncinectomy, after doing an uncinectomy and removing the uncinate right up till the top, then you can go ahead and try to find out the frontal recess without touching the bulla. So without touching the bulla, you try to open the frontal recess. So this technique of opening the frontal recess without touching the bulla ethmoidalis is called as an intact bulla technique. So intact bulla technique, because the bulla has not been touched, so it is called as the intact bulla technique. Now, you may ask, sir, what is the advantage of an intact bulla technique? Now, particularly if the bulla is very well nematized and they extend up to the base of the skull node, what it does is it prevents the exposure of anterior ethmoidal artery. So the anterior ethmoidal artery lies within the nematized bulla ethmoidalis. So thereby automatically protecting the anterior ethmoidal artery when you are doing a frontal recess approach. So that is known as an intact bulla technique. But in certain conditions, I have also told you where the bulla may not extend right up to the base of the skull. So in those conditions, you have what is called as the suprabullar recess. And in some conditions where the bulla also doesn't extend right up till the ground lamella, so that is also then you will have a space between the ground lamella and the bulla ethmoidalis, and that space is called as the retrobullar recess. So a space above the bulla ethmoidalis and base of skull is called as the suprabullar recess, and the space behind is called as the uh, retrobullar recess. So these two things you should be a little careful about, that there is a suprabullar and there is a retrobullar recess. And only when I told you the removal of uncinate, only when you want to address the frontal recess area, then in those conditions only you go for a total removal of uncinate recess. Okay, so this much for today, because I want to take this slowly so that you uh, understand, actually, rather than finishing the course. You have to understand the concept of what is face and what has been what we are doing, rather than just going on. In anyone, today is 19th or 20th?
19,
19th.
sir.
Acha, okay, 19th. So any news whether they are calling you back to the college to attend classes?